So good afternoon. So gone are the days when we used to have cataract surgery for these types of patient who used to wear very thick glasses, and after that, once the intraocular lens came, the it was all because of the this gentleman Harold Ridley who first implanted the IOL in 1949. But the first complication of IOL surgery is presbyopia. That was suggested by that. This name was suggested by Lindstrom way back, and everyone has a desire to be less dependent on the glasses with time and after the cataract surgery, and that led to the invention of different type of lenses, including multifocal lenses. So modern day cataract surgery, the fundamental challenges nowadays are providing good vision to the patients for all distances with the preservation of optical quality and with the reduction or elimination of the various other photic phenomenon. So with the time, the technology has also advanced, and this advancement in technology and the patient pushing for all these or the changing profile of the patient has made the cataract surgery nowadays a refractive procedure, not a simple lens extraction. As far as I am concerned, my journey with the presbyopia converting IOL started way back when the array lens was first introduced in the market about nearly 15 years to 17 years back. And after that, I went for the refractive IOLs, trifocals, and nowadays the new lens, the new in kitty, this VBT, or you can say extended depth of perception IOL. So coming to the evolution of presbyopia correction lenses, the lens which I was just describing was the refractive zonal type of multifocal lens that was coming by the name of array, that was silicon in the silicon platform. It got 5 zones of alternating refractive powers. So actually the lens was giving relatively less dependency on the glasses, but it was associated with lot of halos, glare, poor image quality, and it was actually susceptible to tilt, and decentration could lead to some other problems also. So this was improved later on with the zone asphericity was added on this refractive type of multifocal IOLs. But the most popular was the diffractive type of IOL lenses, which actually the diffraction actually splits the wavefront, resulting in 2 or more distinct focal points at desirable distances. But these lenses also are not without these visual disturbances in form of halos or starburst, reduced contrast, and so many things. So there was always need, or there was always unmet need of having lens which can reduce the dependency on the glasses, but at the same time offer the good quality of vision. So in that step, I think the EDOF lenses started scoring better than in other lenses. So the new lens which has come into the market based on new technology is the X-wave technology, that is the actually utilizes a different kind of surface modulation, leading to this extended depth of focus vision, and that is VVT from Alcon. These are some of the clinical picture of my array lenses implanted way back, and then resume, that was also from that time it was AMO, Abbott actually, or Allergan, that was Allergan, I think. So coming to this new lens, that is the Acris of IQ VVT lens, it has actually simplified the presbyopia correction in the way that this is the first and only presbyopia correcting lens which actually uses different technology, that is wavefront shaping technology, and not like diffraction technology which is there in other type of EDOF lenses. And it has got not only the good quality of good vision for distance near, distance intermediate, and to some extent near one, but it has less amount of visual disturbances, and it is as equal to as monofocal lenses of the Alcon lenses. So what is this X-ray technology? We don't know exactly, but what they claim Alcon is that this is actually, there is actually modulation of the anterior surface of the lens, 2 types of modulations, which actually causes the extended focal range of the vision. This small video clip, you can very well appreciate the difference. Here it consists of 2 surface modulation. This plateau of around 1 millimeter of elevation actually stretches the wavefront, creating a continuous extended focal range, and this central one which has got some change in the curvature actually shifts the wavefront to utilize all available light sources. So these whole changes are made in the central 2.2 millimeter of the intraocular lenses, and with naked eye it is not visible, but under a microscope with high magnification you can really appreciate the change, and here also you can see how it looks like. So this next generation lens actually, the central one actually what it causes that it stretches the wavefront, and which causes actually more for the, which gives vision for more for the near, and the other one, the this zone of plateau actually stretches the wavefront, and because of that there is a continuous range of vision possible from distance to near, but of course it doesn't offer that much of near vision as the multifocal lenses like panoptics. So the monofocal lens only focuses distance on the retina. This does just animation, and the AIOCMTC1 actually stretches the wavefront and shifts the wavefront, so it is able to give clear vision to distance, intermediate, or to large extent near also. So there is a combined effect of stretching and shifting, which actually there is no splitting of the light, so no amount of light is lost, and at the same time because of this there is no, or you can say very minimal visual disturbances. As opposed the Technic Symphony surface, it has got diffraction technology, and which splits the light, and not all lights are going to the eye, so there are some visual disturbances, and near vision is better with the VBT because of this X-wave technology. This point focus spread shows that this lens VBT IOL is able to give good distance, intermediate, and to large extent near vision also. But of course it is not giving as good near vision as the panoptics lenses, but definitely with, as compared to the other lenses, it is offering that. This is again animation, so skip that. So coming to the clinical outcome, that was based on the studies on two independent large randomized clinical trials of 250 patients done for, they compared VBT IOL and the Acrysop single piece IQ lenses, and they found that there was superior intermediate and near vision while maintaining very good distance vision with the VBT as compared to the IQ. And there was, the visual acuity was very much consistent with pupil sizes of, for the all distances. It was not affected by the pupil size, and the high quality of the vision without a spectacle across all distances. And the halo profile, once when they compared it, it was equivalent to the IQ lenses, so it has got the nearly, you can say there is no visual disturbances or as good as Acrysop IQ lenses, whereas with Technic Symphony and at Lara the halos are more in these lenses. So these VBT patients who were implanted VBT lenses reported visual disturbances which was quite comparable to Acrysop IQ lenses. At the same time giving almost equal distance visual acuity and good intermediate and near also. When the Symphony was compared with their monofocal lenses, that Technics, those patients actually, the Symphony patient, implanted patient, were giving or were complaining of more bothersome visual disturbances than the monofocal lenses. So there was some difference because of the diffraction rings, but here because of change in the technology, the patients were not complaining, or complaining, some of the patients had mild problems that was as equal to the IQ lenses. This is the defocus curve, which says that it has got very good intermediate and near, to some extent near also. So because of the flexible defocus curve, it is very much forgiving and delivers increased confidence in hitting refractive targets from the distance, intermediate, and to great extent near also. As far as I am concerned, while when this lens was launched, I took some time to go into it and to implant this BVT IOL, because for any fresh lenses, I take some time to actually and never jump to suddenly start using that. Once I get convinced, then only I start using. So I have been using Panoptics in those patients who actually wanted trifocality, but since there was some points which was going against those patients for Panoptics, like young patients who were indulged in night driving, or who are very active. So most of the those patients, it was very difficult to put these Panoptics lenses because of the post-operative visual disturbances. So in those patients, there was options of using those lenses where the visual disturbances was least. At the same time, it was able to give best possible distance intermediate, and even if it compromises some amount of the near vision, then it would be always a better. That was my thought. And nowadays, since most of us are now involved in intermediate distance usage like computer, mobile, so this intermediate vision matters a lot for particularly the younger generation, and not only younger, almost everyone is using computer or mobile. So in those patients, if you want to give a good quality of vision without compromising the distance, the visual disturbances, less dependency on the intermediate and to some in the near, I think BBT is a better. So I started using that, and based on that, I started using around 1.5 years back. So total I implanted 65 IOLs, toric in 13 and plain BBT in 52. Bilateral patient still in our area, I don't know why most of the patients they try to defer the surgery for few months, few weeks, few months, but some of them underwent bilateral implantation. And with BVT, I was able to actually shift to younger patients also. Those patients who were very much active. And you see here, female patient was one only, because most of the female patient, if they don't bother too much about driving, so they want very good near vision. So all female patients actually went for Panoptics, but in male patients who were active, many of them were health professionals also, and younger generation. 45 was in less than 50 years of the age, and I operated in some of the surgeons also, and they started doing surgery without using any glasses. So they claim that many times you will need glasses for near around 1.5. In my case, around 25% of the patient never required any correction for near, and maximum number which was given to a patient was 1.25 diopter, and majority improved with 0.75 diopter. So even though it was initially said that they actually marketed like that for near sir you might use glasses, but in my patient, many of the patients they were off glasses without any problem. Of course, in some of the bilateral patient where one eye actually required plus 1.25, I did some micro monovision correction, and that patient was again very happy. So only 2 patients complained of glare, but they were never so bothered to the extent that they always keep telling or keep coming. But they said that thoda bahut problem hai, kind of thing. So just to summarize, Actresop IQ VBT IOLs delivers an extended focal range with a visual disturbance profile comparable to Actresop IQ, and this gives extended range of vision from distance to functional near, and some of the patient may require near correction, and there are least possible visual disturbances as opposed to many other lenses available, and being the first of its kind, this X-wave technology, I think that this lens is going to stay. Thank you so much. Any questions?
What are your experience that if you have a 0.75 cylinder?
Sir, if the patient has, sir, 0.75 up to 0.75 easily they accept. What I do, I make the incision on the steeper meridian, and once it is 1, I always use this toric, because even slight amount of astigmatism can cause much more disturbances in trifocal or this kind of lenses as opposed to monofocal. Yeah.
Yeah, that's been our experience also, that even astigmatisms of the order of 0.5 and 0.75, if it comes, is not well tolerated.
Yeah.
So it's always advisable to use toric riveting as and when required, or steep axis incision.
Only thing is that I think that it is little overpriced this lens.
Yeah, that is, so is a universal complaint, so what can we do about it?
But at least one thing that has been good of late is that they have equated the prices
Yeah.
of
Do.
optics and riveting.
Yeah, yeah.
So you can just counsel the patient regarding the focality and then choose according to individual needs which suits that particular.
They equated how? They raised the price of the panoptics and brought it down to nearer to that.
Some sort of balance has to be struck
Yeah.
because the industry also looks at its own.
Yeah, yeah, yeah.
We are all entrepreneurs and we understand that everybody is working here for the
Yeah.
benefit of the organization. So we can't really keep the manufacturing hubs out of this. So we also work out our own mechanics, how to generate a bit of profit for our organization. So
Yeah.
it goes with them also. So obviously there has to be a balance struck somewhere. But I think it's a good concept that this has been equated so that you can choose according to the need of the patient, and you are the
Yeah, that's important point actually. Yeah.
No, Anurag, essentially pricing has been a very important issue. I mean, the industry or the Alcon, they say that under promise and over deliver. Now, if you're charging 3 times, how can you under promise?
Yeah.
So the promise or your, it is in the price tag. So essentially, I mean, if you were to ask, see, the pricing comes from the Western market, and there, especially the US, Alcon being predominantly, though a very international company, but starts from the US, because there are doctors who do Medicare and who don't do Medicare. So in Medicare, this lens is not approved. And the other practitioners who would not do Medicare, they have patients who can afford and they want to differentiate themselves. And these surgeons also, they are high price surgeons. So for them, the lens costing much wouldn't make much of a difference. But in Indian context, it makes a lot of difference. That's true.
So thankfully, I think the recent experience shows us that a lot of insurance companies have actually started giving approvals for majority of them. In fact, all of them are giving approvals for torics now, all of them virtually. And the EDOFs and the trifocals have also started gaining in some sort of foothold. Largely it has come from the patient's feedback and the patient's demand and insistence that I want this in my eye, so you have to give it. And once they give one approval, the others have to follow suit. So we are at a place, fortunately, I am at a place wherein the PPN thing doesn't work. So it's not one of those CTs where they insist you on a PPN. So we are getting approvals, but yeah, not consistently enough. That is true. Right, so good afternoon, ladies and gentlemen. This is basically pertaining to how I prefer to operate using my Centurion Vision system. And basically it is bringing in the IOP to as much as possible. In fact, the lowest standards that the machine allows is where my preferred limit is set to. It's 20, the IOP that I use. Before Active Sentry came in, it used to hover around 20 or 30. But now, after Active Sentry has come in, it is essentially 20 for all the grades of cataract and all the types of presentations that the patients come with. I'm not going to the details of this because we don't have audience before whom we should be speaking about it, because I mean we all have dissected the inside of the machine. We know how things work there. The only thing that Active Sentry has added on is the additional irrigation sensor in the handpiece, and I think more important was the discovery or the invention of the balance tip even than Centurion itself. I hail the balance tip more than Centurion for the dynamics or the phaco-mechanics part, because with the balance tip this actually unleashes its beastly power, which with the Kelman tip, if it would have been there with the Centurion system also, it would not have probably given us the wow feel that the Centurion is giving us now, just because of the presence of the balance tip. It is absolutely phenomenal. Recently I had an issue with the irrigation sensor in the handpiece not being able to calibrate itself properly. So if you're taking Active Sentry, just be watchful, because at times the machine might not be able to calibrate itself. So you might just have to shift to the non-Active Sentry mode, and there's some issue with the handpiece. The engineers are still looking into it, why it happened. So the reason why I shifted to a low IOP phaco are basically three. I consider phacoemulsification not to be a surgery. If you imagine the surgical process to be a transient courtship between the patient's eye and the surgeon's hand, then it is perhaps imperative that in a courtship, as both spouses take care of each other, they ensure that the other spouse is comfortable. We also have to ensure that the eye is comfortable, which we are touching and handling. So that makes physiological IOP much more legitimate. I'm a very miserly person. I'm a typical feudal Brahmin, so I'm very penurious. I don't want to spend much, not in terms of money, not in terms of power, not in terms of fluid as well. So that's why I shifted to low IOP. And how it has served me is what we would see in the form of a few video examples. So this is the first case where the pupil was not that great to start with, and when we incised and started doing the rexes, some eyes do have this tendency. The pupils started really dying on me. As we were doing the rexes, it gotten smaller, and when we were doing the hydro, it got really small. This is not a stage where we can implant a pupil expansion device, the iris hooks being the only choice. But I always decide to go ahead with the phacoemulsification without implanting any device at all, because I trust my machine and I trust whatever little skills I have mustered over the years. So we just need to stay at the middle and trust the effect of the fluidics really that well. The vacuum I always have set in my machine is around 400 and 450. So even if the occlusion breaks, it doesn't really pull in the tissue that is surrounding it. The danger in such circumstances is the iris being dragged into the phaco port. This is an unedited video, just been sped up in the interest of time, and you can see how quickly it has finished off all the pieces, and while the needle is right at the center. So this is the first example. This is a lens-induced glaucoma, as can be seen, with a little bit of AC reaction, which is now subsided with the help of corticosteroids. So these little synechiae have to be broken first. The lens is very intermittent, as is expected. So a mechanical pupillary dilatation is also produced thereby. We are using viscoelastic so that it dilates to sufficient proportions. The initial nick has to be careful, because we know that the milky cortex will leak out, so the nick has to be small, and then with the side port, the microrhexis forceps goes in and then rotates the capsular flap to produce a rhexis which is good enough in size to allow the subsequent maneuvers being done. All the while we have to keep in mind that it turns or runs outwards, behaves very erratic at times, so time and again it has to be inflated with viscoelastics, and a forceps always is a better tool than the needle to complete the rhexis in such cases. But once that is done, the nucleus management again becomes easy. The IOP stays at 20, and mind you, such cases the anterior chamber was shallow, is shallow more often than not, but still the IOP of 20 does a reasonably good job. This is done without Active Sentry, and you can look at the stability of the anterior chamber despite the vacuum sitting at 450, and in panel mode it doesn't show a dip towards the end. The IOP is 20, reasonably hard cataract, shallow AC, but still it does a reasonably good job. In fact, a very good job in keeping the anterior chamber bloated all the time. Now once that happens, you don't need extra space, or you don't need to bombard the anterior chamber with fluid. You just need some space to work with. Your business has to be done without putting any other important delicate structures around. So it's over in a jiffy, despite the IOP being so low. This, on the other hand, is another type of white cataract which doesn't rotate, and once the nucleus is not rotating, we get the feel that the nucleus is not very hard. Despite of attempting it by doing a hydrodissection from multiple points, it still is not rotating. So the nucleus is not hard. In such cases, Centurion has received its criticism for being too harsh on soft cataracts. So what we should be ideally doing, what I do ideally in such circumstances, is not to attempt a chop. I use a trench, but not using any power. You can look at the CDE, which stands at 0. So I'm not using any power, just trenching it with vacuum and create a deep enough trench. So this is the safest way, I believe, of not harming or not suddenly entering the nuclear substance and inadvertently touching the PC. So it divides beautifully. The CDE still stands at 0. It doesn't have to go up. I have switched off the power completely and just operating with vacuum. But the IOP all along has stayed at 20. So if you have a high vacuum setting and using only fluidics to operate on a soft cataract, the IOP does have a role to play. So the second instrument, of course, plays a role to levitate the nuclear pieces out of the bag so that they can be consumed using only vacuum and not using any power at all. Our skepticisms are justified because if you use power, since we have to go to the mid periphery to grab hold of the nuclear fragment in such cases, there's always a skepticism of it creating a hole, punching through, and then going into the PC and sometimes rupturing it. But more often than not, it doesn't happen if you don't use any power at all or use minimal power. So I'm not using any power in this case. One can use a 5% power if one is not comfortable using with fluidics alone. But the important impression that we achieve from this particular case is the ease at which the vacuum is aspirating the pieces which are cheese wiring without causing any fluctuations in the AC. It is not dipping. It is not causing any fluctuation in the AC despite of the IOP being pretty low on value. This was another case wherein the endothelial cell was not showing any count on the specular microscopy, as you can see in the picture. It was very, very low indeed. So luckily for us, the patient just decided to get a flax done. So we went ahead and did it after adjustment. After adjustment to the capsular margins. The cursors are being placed to identify the highest and lowest points in the anterior capsule. But since the endothelial cell count was low, I decided not to do the nucleotomy too deep. I stayed at a superficial plane. I just wanted the laser beam to give me a cleavage plane so that I know where to crack. But I didn't want the laser beam to travel through and through because I wanted to save on energy because the endothelial cell count was low. So when the laser started, it did the capsular axis. Of course, I always do my corneal incisions with the laser. I never ever switch them off because I love doing the corneal applications with the laser, and I think the biggest fun working with the femto laser platform is the corneal applications, not the rexis, not the nucleotomy. I enjoy doing my corneal incisions with the femto laser, and then the corneal incisions are being made. When we shift this patient to the OT front, we would see that this is pretty hard cataract, and the patient was one-eyed. I forgot to mention that. The patient was one-eyed, endothelial cell count low, and hard cataract. So the new corneal incisions always open pretty smoothly. This is something that always happens. We can see that there are templates produced scratches, but they are very superficial. So once we start the emulsification process after doing the soft shell technique of viscoimplant, we would see that since there are cracks made already, we do have planes, the chopping becomes a little easier. However, the one thing that does not change is the IOP. The IOP is stayed at 30 here, not 20. I'm not using active sentry. But look at the way the chopping happens. Because we have an idea, a guideline as to where to chop, the pies are separated quite uneventfully and smoothly without using much of lateral force with the second instrument. And then the emulsification process starts, and once that happens, look at the CDE. Since we have lasered to fragment it at least superficially, the CDE count is pretty much acceptable for a low endothelial cell count, even if the cataract's quite hard and quite leathery. So this was the 7 days, I think not 7 days, 4th post-op day picture of that same patient doing pretty well. I'll just keep this and go to the next case. This was again a one-eyed patient wherein there was a long-standing corneal scar due to a pseudopterygium. I didn't find any point in removing it. This is a Gupta's ring, an Indian counterpart. Looks similar to Melugan, but doesn't exactly function like a Melugan. The behavior of the pupil is also a little different from what you have in a Melugan placement. That essentially renders the pupil round, whereas this converts it to a little squarish shape. But post-operatively, it behaves quite well. It actually preserves its light reaction quite well. But the thing is, again, the IOP is 20. The nucleus is not the softest that you come across, but still the separations happen quite interestingly. And in this case, after the nucleus implant and the IOL, what we will do is we want to explant this pupil expansion device under cover of BSS. I'm not interested in using any viscoelastic after it is implanted, after the IOL is implanted. So under cover of BSS, we would be trying to dislodge the scrolls one by one and then remove it. I have scaled up the IOP to 55, as you can see, and the left hand, which is holding the irrigation cannula, is supporting the ring on top of it, so that when it is completely dislodged from the pupillary margin, it should not shoot and cause a damage to the endothelium directly. So the left hand instrument is just supporting the ring while the scrolls are dislodged by one, and then one of the scrolls is aligned again the main wound by rotating it a little bit, and then a pair of Macpherson forceps just go grab the scroll, one of the scrolls, and then just pull it out just like that. I mean, you have to maintain an oblique plane to pull it out all right, but it actually behaves well. And once the ring is removed, you can look at the pupil, it still maintains its circularity quite well. So Gupta's ring works well, but it's just that you have to extend the section to 2.8. It doesn't go through a 2.2. The next case is loaded with asteroid hyalosis. As you can see, it masks the red glow. We operate the patient under an IOP of 20, which is a very soft cataract, so there's nothing much to do in this, and there's no heroic in doing of this case under an IOP of 20, so that's not a very difficult job. But what comes after this is quite significant. I mean, after the IOL implantation, I decide not to leave the patient like this. With so much of asteroid hyalosis roaming around in the visual axis, you cannot ensure a good vision to the patient. It might be a difference between a 6.6 and a 6.12, but still the patient suffers on visual quality. So what I decide to do is I implant the IOL. Now the IOP has gone up to 55. I have slightly increased it, and with the right hand, under cover of BSS alone, I switch the microscope's view to microscope's illumination to red glow only, create a small opening in the posterior capsule, and grab it with the micro excess forceps and convert it into a PPC, and then take a vitrector, go deep, and do a proper deep vitrectomy. As we remove the liquefied vitreous cortex, and along with it the asteroid hyalosis, look at the way the red glow comes back. So all the moving particles, the opacities are removed now. The red glow is brilliant now, and this patient is obviously going to be having a very good vision in the post-operative period. This is another case wherein there was a posterior polar cataract, and it was a young patient. After implanting the IOL under cover of BSS again, I decide to remove the central PC plaque, which is occupying the center of the visual axis. With the help of microrhexis forceps, I go ahead under the IOL, place a nick first. So this is something, if you're not using viscoelastic and doing of these steps under cover of BSS, then it is a little tricky. I completely understand that, but it's not doable. It is pretty much doable. You just have to have that much of control in the right hand. So now we can see that the plaque is removed. Now I challenge this machine to the extreme extent possible and see whether it can perform. So in one of the examples, these are numbers, as you can see, case number 4. So this was with one bag of BSS after its priming and tuning is complete, which leaves you with 360 milliliters of fluid. And then I started my first case. We are in the fourth case in the same series, and we would go up to, so this is perilously close to, you can look at the volume of fluid now in the bag is reduced down to 40, and still the last case was done with 40 milliliters of fluid. This will be further exemplified in the next case. This was the last case. This is how the machine is challenged to the extreme. This was the last case for that OT on that day, and my assistant said, should I change the BSS bag? I said no to him. I thought I would carry on with 40 milliliters of fluid in the bag. Now, this could be a misadventure, and I might have to top it up somewhere in the middle of the surgery, but I hope that it will not be necessary. So after hydro dissection and delamination, we proceed with the case. The fluids keep on depleting to perilously close levels to zero, and the machine stopping altogether. Now you can do this in the event of two things. One, the machine has to support you till the last drop of fluid in the BSS bag. It should not stop in between. And the other thing is it has to consume less fluid. So only then would you be able to manage cases with such little fluid in the bag. So on an average, this is what it takes, the volume of fluid for one surgery. So we are reduced down to 30. So with the 10 milliliters of fluid, we manage the whole nucleus, epinucleus management. We're still left with 30, and we initiate the cortex management now. The cortex is being removed as fluid further depletes, but the IOP stays at 24. So even now we are not using much fluid. So the cortex management is over. We are still left with 30 or 20 milliliters of fluid at the most. And then we expand the section under cover of BSS. A multi-piece IOL goes in. Under cover of BSS again, I don't use viscoelastics to implant any IOL. So that goes true for multi-piece IOL as well. So you can see the bag, it's still showing 20 milliliters of fluid left. So lavishly all steps being done, no compromises, no hurry. You don't look like you are in a hurry or in a haste to finish off because you don't have fluid support in the bag. But the machine supports you so beautifully that even if it's challenged to the extreme, it still supports you to the last drop, and it doesn't show any flinch in the anterior chamber depth. It's beautifully maintained right throughout. So that's it in this segment. Thank you so much. If there's anything, we'll take it up. Mike.
Another very big advantage of this active fluidics is in those patients who have undergone vitrectomy. So in this situation with this much of the intra-IOP, we can just avoid sudden deepening of the anterior chamber and other things.
The reverse pupillary block. It also works well with the high myopics.
High myop also.
They don't complain of any pain. It's true. Very true. So earlier on, what we used to do was with a second instrument, with a chopper or the dialer, we used to lift up the iris so that the reverse pupillary block will not happen. But in this case, you don't have to do anything. No customizations in anything. It's just the fluid flow is so less that it doesn't cause a reverse block. So this is about the other equipment that comes from the same house, the operating microscope called Luxor Revalia. Now the Luxor was introduced to the market way back, and then it was withdrawn because of very subtle technical glitches, and now it has been reintroduced. And why I have named this topic such is that the Luxor Revalia, as you would find out in subsequent clips, it produces the best red glow in terms of quality and in terms of dimension. The red glow stays for a very long while, and it has a huge bracket or huge margin till which so it doesn't shift or doesn't go away with the moving of the head or moving of the head of the microscope. So it's not a sweet spot where the red glow appears. It appears all throughout your surgical field practically, as we'll see later on. So this is a view of an eye from outside the microscope. You can look at the cataract, and this is how you look at it. This is how it appears from outside the microscope. When you look at the same eye through the microscope, which is projected on the OT monitor, it looks like this. So it's almost like there is no cataract. You can't find a cataract. This looks like a normal clear crystalline lens. This is a picture taken from the monitor. So you can imagine the quality loss that has happened. So if there's no quality loss like that, and if you get a direct surgeon's view as I'm getting here, you can imagine the view that is something you're receiving. So a very routine case, just look at the movement of the eye. That's something that is to be emphasized here. Look at the movement of the eye during various steps and look at the stability of the red glow. It doesn't shift one iota in terms of its resolution or its clarity. It stays that brilliantly red all the time. What it has actually extrapolated to in my practice is there are two things that have happened. First is, touch wood, the rate of complications have significantly gone down because you're not imagining anything, you are seeing everything. And then, which is of course very, very important in our kind of practice, which are, all thanks to the grace, a little high volume, it has increased the speed of my surgery and by considerable glitches. I've really started doing many numbers more, and even if the list is really, really, really long, I don't spend more than 5 to 5.5 hours in the OT on any day. I don't have to, because the per unit disposal time from the OT is that much more. So this is about a routine case which finished off, and till the end of it you can see how brilliantly the red glow is appearing. Now coming to the machine proper. This is the handsomely looking dual tone Luxor Revalia for you. It has two screens. One major screen which is at the hind end of the microscope, hind end of the body, and then one minor screen which sits right on top of the surgeon. So there are minimal adjustments or customizations that you can make from the minor screen which is right on top of the surgeon's head, and then the major customizations or setting changes have to be done from the screen that is behind it. So that's fully loaded. This one's not fully loaded though, but it does the job all the same. So you have visualization, of course, is very advanced. The optics is, it doesn't have a brand name to boast, but the optics are beautiful. It has a depth perception of 65 millimeters. So the buffer zone is 65. So a lot of times using the foot switch, we have to fine focus on the eye, to focus on different structures, from the cornea to the anterior capsule to the posterior capsule if need be. Since it gives you a buffer of 65 millimeters, even if you are focused on the cornea, you can clearly see the posterior capsule. So that extra effort of adjusting the fine focus is not there. These are very little things, very little niches, which actually reduce the surgical time a lot. The illumination is very personalized. How? You can fractionate the oblique illumination and the axial illumination. In other microscopes, there are just three positions. In one, you get only oblique. In two, you get oblique and coaxial combined. And in three, you get only coaxial. Okay? In this, you can fraction it. You want 30% of oblique, 70% of coaxial, fine. You want 40% of oblique, 60% of coaxial is also fine. And then you can individually increase the brightness of each of these three illuminations. This is the customization of the illumination that can happen, the personalization happens. And then you can set your profiles. If you are in a center where there are multiple surgeons, just like the phaco machine, you can set in your parameters. The moment your name is clicked, your customization comes in. The other thing that is noteworthy is, if you've looked at the other microscopes, the moment you go to the stereocoaxial illumination alone, the resolution always drops. You don't have the same depth perception when the stereocoaxial works alone. The depth perception is always better with oblique. So we always tend to keep the knob in position 2, where there's a mixture of coaxial and oblique. In this, even if you make your coaxial 100%, you do not compromise on resolution with this microscope. So it is that good. These are the three types of illumination they come with: warm white, cool white, mixed white. If I'm permitted to say this, I did not like the cool white and the mixed white at all. The warm white is, of course, something that they install most commonly, and that is the best illumination that I found out of these three. So this is what coaxial illumination is. It is actually an intersection of two circles that are happening, but in terms of the difference that it bears from the other microscopes in the industry is that they have a convergent system, this has a divergent system. So that is how it expands the area in which you appreciate the red glow. It does not stay pertaining to a particular area. Even if the eye moves or the microscope moves, the red glow still stays pretty bright. And this was the 65 millimeters that I was talking to you about. It gives you a buffer of 65, so that even if you don't have to really move up and down to stay focused on the eye, even if you are staying on focused on the anterior capsule, it can pretty much show you up to the posterior capsule as well. So 47% greater depth of focus. And then you can also change things in the foot switch, 1, 2, 3, 4, customize everything. And this is how you can change. So you can look at the central circle. The coaxial here is 100% and oblique is 40%. That's where I prefer to keep it, but you can always keep on changing the way you like it, and these are doctor settings that are there. So these are the controls. So let's just go to a few case examples. This was one case which was a very intermittent one, as you can see. So as is usual, I tried to do a rhexis, which I thought was running out. So I tried to push in viscoelastic, but as I was doing so, it actually gave way and Argentinian flag happened on one side. I tried to retrieve the rhexis by pulling it back to the center, and I failed miserably. As I was trying to give a cut to retrieve the rhexis, the Argentinian flag sign extended and involved the other equator as well. So I was in a doom. This patient was selected for a premium monofocal IOL and didn't want to convert. So I gave a nick and continued with the case. I encircled and created a flap of whatever little available capsule that I had in hand, and then did a minimal hydrodissection just to ensure that the nucleus moves a fraction, which is enough for me to chop and remove it. And then I started operating on the case. Now, following the guidelines that's so beautifully lamented by Dr. Rohit, this flap was not extending to the PC, but the visualization was important because I was seeing where the flaps were exactly. I was seeing all along the posterior capsule beautifully. I knew that there has not been an extension. You can look at the view, it's unparalleled. And after the IOL has been placed, which is single piece, and the haptics have been aligned in the available portion of the capsule, then I decide to extend the rhexis margin to make it look more circular while the coverage is being adequate. So I do it under the cover of BSS. No viscoelastic needs to be used here. Just flaps on either side port, introduce the micro rhexis forceps and complete the flap just like that. This is another case wherein the behavior was similar. It was also intermittent, but the rhexis did not run out in this case. However, while I was doing the case, something happened for which I just received a jolt and I thought something was wrong. As I was removing the second piece, look at that, just carefully look at that. This is how the PC behaves. It blobs and you know that you have touched it somewhere. So I pushed in viscoelastic and dislodged all the nuclear fragments on top of the capsular bag. I took them out into the anterior chamber. This was a one-eyed patient who needed a T9 toric implant. So there was no possibility of me implanting a multi-piece IOL here, even with an optic capture. So I decided to go ahead with phaco. Use the toric IOL for scaffold here. Normally we use the multi-piece, but I decided to use a toric IOL for the scaffold here. Just inserted the advancing haptic into the sulcus first, so that I have a posterior support on top of which I can emulsify the nuclei one by one, fragment by fragment. After that is done, the nucleus is rotated. There's quite a large PCR happening there, but the haptics are tucked in, holding them from the bend gently so that they go just beneath the anterior capsular rhexis margin and then occupy the. Fortunately, the rent that had happened was right in the center, so we still had support in the periphery so that the haptics could be tucked there and could be aligned. One haptic has gone in, the other haptic was in the sulcus, which was the advancing haptic. Now that is caught hold of and gently pushed behind the rhexis margin, and what we are left with now in the bag is a bit of cortex, which can always be removed later. So the alignment happens of the toric IOL, the bimanual IA clears out all the cortex that's remaining, and then a little bit of vitrectomy if it's needed. There's not been much of vitreous loss, all thanks to the scaffold that provided the vitreous support. So a little bit of juggling with the IOL to align it along the desired axis and then form the AC to close. Okay, so an advanced visualization with a brilliant red glow is what helps me in cases like this to achieve what I have promised the patient, and it has worked there and beyond, all thanks to the Luxor Revalia microscope, which actually provides a brilliant view to me all the time. And what we see here in the form of recordings is just 20% of what you see as a surgeon, because I use a 80-20 beam splitter. So 20% is what you see here. So you can imagine 4 times of that would be that much brighter. So thank you so much for the attention. All done. I think we should hand over the session to the next chairpersons. Manish, you're taking over?
Sure. Thank you so much.